Our next speaker is Julie Paradis. She's also a researcher at KCE, and she will be talking to you about the implications of the framework on children and their unmet healthcare-related needs. Julie.
Yes, thank you, Anne. So, hi everyone. Now that you are familiar a bit more with the need approach, I will present you the paediatric need framework. Childhood diseases often have low prevalence, and many of them fall into the category of rare diseases. Although the importance of randomized controlled trial in driving innovation is well established, they remain rare in pediatrics and are generally not funded by industry, even for the highest burden conditions. This often leads to the use of off-label treatment, which can carry clinical risk. Beyond those risks, children with health conditions experience stigma, limited access to appropriate care, and low quality of life. Childhood is a critical window for intervention. For instance, more than half of adult mental health conditions start in childhood. UNICEF has called for children to be seen, counted, and included, highlighting the significant lack of pediatric data. Children have the right to a protective, supportive environment and to participate in decisions about their own care. The NEED approach supports this goal by strengthening data collection to help steer development and improvement of existing solutions that genuinely reflect children's needs. Here is the pediatric framework currently under development. You can see similarities. We kept the same structure than in adults. So you have the dimension and domains that are the same. We retain relevant criteria and indicators from the adult framework. Others were modified, others were added, like impact on development or impact on family. And in fact, when we go down to the level of indicators, we had to create 3 frameworks. One for children age 0-3, one for children age 4-11, and one for children age 12, 17 years and 12 months. Indeed, childhood is marked by rapid and profound changes, leading sometimes to different needs. Let us now take a very brief look at what is this development. At the individual level, childhood is marked by major transformations that shape their development. The brain, as the major organ of voluntary actions, undergo a rapid expansion. And for example, as you can see in the figure of the cortical surface in the first 2 years with the convolution and the folds. And not only in the early years, some brain areas continue to mature around the age of 21. Physiologically, growth is equally remarkable. For example, weight triples in the first year, age increases rapidly, and another major period of change is puberty that triggers a new growth spurt, body composition change, and hormonal maturation. This is really brief, but we can therefore well imagine that the consequence of disease might present certain specificities depending on age groups. All of this development are only possible through interaction with the environment. Children's brain, body, and behavior are shaped by the world around them. Learning and play through social interaction are central to development. Families are the first and the primary close relationship a child has. Gradually, friendship emerge. For example, at age 1, it's share smile. At age 5, it's birthday party with peers, and 15, intimacy with close friends. All these interaction support social and emotional skills, all closely linked to child's development. At the same time, autonomy grows in daily activities from simple action like getting dressed to more complex ones like taking the bus to visit friends or managing a bank account. All these individual and social changes are important to consider, and they might be challenging when assessing needs when health conditions disrupt the development. Childhood, to conclude more or less, is a fragile period because many function and foundation for the future has been established. And at the same time, it's a window of changes and opportunities which makes it such an important time to identify needs and to intervene. We know that the consequences of pathology very often does not stop at age 18, but often impact adulthood, like impact on work, productivity, social relationships, all of this having a cost for the individual and the society. This leads us to a perspective based on the life course. Hence, the NEED PEDIA framework maintains a certain consistency with the adult framework to study pathologies on a life course perspective. Our first steps involve a mapping literature review with a systematic approach on 3 common databases, Ovid, Medline, and Cochrane. We looked for articles about unmet pediatric needs, health and healthcare, with all pathologies included children from 0 to 17 years and 12 months. 1,682 abstracts were blindly screened by 2 experts. 312 articles were retained for full analysis. They were, as you can see in the table, qualitative mixed studies, quantitative studies, reviews, and questionnaires. The population included was between 0 and 17 years, 12 months. We had articles about including children with health condition, a very broad spectrum of health condition. Some articles were about parents' needs or family needs, like siblings. We had articles on children with vulnerabilities, like, for example, homeless children or immigrant children, and children from large cohort of general population. Based on this full text of 312 articles, we first categorize deductively, using the box you see here, in the adult need framework. But we also made an inductive analysis, so meaning that all specific children's needs that did not fall in this adult need framework were put in a sort of a box of child-specific items. In addition, we created categorization rule to qualitatively extract in a systematic way the results of the different article types. Based on that, we created a file with the criteria, indicators, measure, and example of original quotes from the article to illustrate it. After analysis and team brainstorming, we have obtained a framework with 27 criteria, with 1 criteria specific to adolescents after 16, 52 common indicators, and 5 age-specific indicators. The second step, where we are now, is to consult experts, clinician and lived experience experts. It will be really important to improve and fine-tune this proposition. Now, let's have a look at some of the challenges we ran into while developing this work. The first challenge concerned the impact of the disease on child development, for example, as a result of medication. Clinically and at the population level, as you can see with tools like ECDI or MSD, parents are asked about the skills the child had acquired, and this is compared to age norms to give a score. We all know that children develop at a different pace. So it means that for NEED studies, it would have required a very large number of children in each age group. It would have required the parents to fill a lot of questions only for these indicators. And in addition, we would like to know whether the delay in development remain on time, over time, or if the child catch up with time, for example, after the medication. For all those reasons, we decided to ask clinicians 1 question about the impact of the disease or the treatment on children's development across 4 domains: cognitions, motor skill, language, socio-emotional abilities. Experts have to rate for each dimension the persistence over time and the extent of the impact on daily life. Another challenge concerned the choice of the quality of life tool. There's a lot of tools in the literature, but usually it's really rare that the tools go from 0 to 17 years, 12 months. The EQ5D5L is a well-known tool providing cost-utility score. It is a tool used in the adult need framework, and they develop 3 different tools to allow us to study quality of life from 0 to 17 years, 12 months. Therefore, we choose this one. And as you can see here, if the child has between 0 and 3 years old, we will use the EQ-TIPS5L. If he has between 4 and 15, the EQ5DY5L, and above 16, the EQ5D5L adults. But in order to assess the impact of the disease on quality of life, we mean to measure the difference in score between the first symptoms and today. Therefore, depending on when the child had the first symptom, we will use the EQ5DY5L or the EQ tips. Of course, for children who have had symptoms related to the disease since birth, the question about before symptoms will not apply. Another challenge was the transition of care, which straddled both the pediatric and adult frameworks. As you can see in the picture, it is usually described as a 3 period, so the pre-transition, transition, and post-transition. It usually starts it's recommended to start at around 14, and then at 16, between 16 and 20, it's the period of effective transition. This transition is not only physically transitioning to adult care, but it's a series of events to help and support the child to gain autonomy, skills, and to manage his own health care. It's, for example, counseling and education. And in fact, looking more closely at statistics on children who are transitioning to adult care, particularly in this study Milestone, we realized that most were still in the transition process by the end of the pediatric framework. This means that we couldn't simply ask whether the process had gone smoothly. Instead, we decided to focus on whether the process had been initiated after age 16, which serve as an indicator of quality of care. Another challenge was that pediatric healthcare has many cultural aspects and approaches, children-specific. There are recommendations from the WHO, the Council of Europe, a lot of different reviews in the literature about concept and components of child-friendly care. Very briefly, it represents an intersection of pediatric healthcare excellence and children's rights. In the NEED-PEDIA framework, we were inspired by this definition, and in the quality of care criteria, we retain the indicator of the adult need framework in gray, coordination and continuity of care, receive information, appropriateness of diagnostic timing, involvement in treatment decision for both children and parents, time from first presentation to diagnosis. And we added 3 indicators: the quality of communication with the main healthcare provider, child-friendly inpatient care environment, and transition to adult care. Finally, a major challenge we often face in pediatric studies is who participate in the research. Depending on the age, it might be a bit difficult to ask on an online questionnaire for a child to rate on a 5-level scale his quality of life. Pediatric teams have developed nice questionnaire using a more binary and visual approach, like in the PEGs here, to define children's goal in rehabilitation. You can see here that the researcher asked the child in those 2 images, which is the child in color that represents the most him or herself. And once he has chosen, then we take the image and we ask him if it is a little bit like him or a lot like him. And this, in fact, replaced the 4-point VI scale used for adults, not at all, slightly, moderately, extremely. In NEED, we have to conduct an online survey with a large number of questions, recruit a large number of respondents. Therefore, we plan to go for a parent report questionnaire from 0 to 12, and an hybrid version for adolescents, where adolescents can fill in part of the questionnaire that regards them, and the rest can be filled by parents. In interviews, we are planning to adapt the interview to adolescents to give them a voice. This work was possible thanks to this amazing team, so thanks to them, and thanks you for listening.
Thank you very much, Julie. There will be time for questions later, but now I want to introduce the next speaker, Zilke Claessens. Zilke is a PhD researcher at KU Leuven, Department of Pharmaceutical and Pharmacological Sciences. She has previously collaborated in one of our studies in the NEED project, and she continues her work to advance the evidence base for more transparent and patient-centered prioritization in healthcare. Zilke, the floor is yours.
Hello, everyone. I'm not sure if this presentation is going to start by itself. Just have to start? Okay, hello everyone and welcome. In this presentation, I will present to you the first actual complete case study of the NEAT project as presented previously. This case study was performed in psychotic disorders. So within this study, we aim to identify the unmet health-related needs associated with psychotic disorders. Before I start, I would like to give you a small introduction of what psychotic disorders, or PD, actually are. So it's an umbrella term and it covers various conditions, among which, for example, schizophrenia. Schizophrenia is probably the most known and also the most researched one of them all. Psychotic disorders are characterized by various symptoms, and we cluster them in 3 groups. So, for example, positive symptoms. So patients experience delusions or hallucinations, but there's also negative symptoms, which include, for example, decrease of emotional expression, but also reduced motivation. And then lastly, there is also cognitive symptoms, such as, for example, a reduction of working memory. Some key facts. So globally, psychotic disorders, including schizophrenia, represent 3% of our population. In terms of origin, it is often a combination of genetic vulnerability, but also environmental factors, such as, for example, trauma and substance use. Specifically to schizophrenia, we see that the onset of the symptoms occur around the 20s. For men, a little bit earlier than for women. And then also specifically to schizophrenia, we see that there is a reduction in life expectancy of around 12 to 15 years. And this is mainly attributed to an increased suicide risk. So that was it for my introduction. Now the approach. I don't think I have to say a lot more about the methods as they were presented over the various previous presentations. So what we did in this study, we applied the toolbox developed by KCE. And for this presentation, I will focus mainly on results from the literature review performed by the KCE team, but also, and most importantly, the application of the survey, so the patient questionnaire, and in-depth interviews that were conducted to get a little bit more of detailed insights on the actual needs of these patients. Going further, so what we did is we applied this generic NEAT toolbox developed by KCE, and we adjusted it to tailor it towards our specific target population. To do so, we talked to patients, we performed some pilot studies, we tested the instrument for sensitivity, for example, we changed some wordings, but also we tested for the length and comprehensibility. And this ended up in an adapted NEAT toolbox specific to pediatric disorders. In terms of recruitment, there was a question earlier on how we actually do this, how we reach patients, how we reach caregivers who can participate in the survey. So we aimed to recruit as broad as possible. Therefore, we involved various actors, such as, for example, psychiatric hospitals, but also care home, general hospitals, healthcare centers, patient organizations, and sickness funds. And the aim was to really get this representative sample across Belgium. We used posters and flyers, as you can see here in French, but they were also available in Dutch. Then, this recruitment strategy resulted in 377 participants who initiated the survey. Unfortunately, there were quite a bit, as you can see on the right, who didn't complete the survey. So around 200 completed it, of which a couple were excluded because they didn't meet our inclusion criteria. So we ended up with 159 participants included in the sample. But who are those patients? Some descriptives. So most participants in this survey were persons who had a psychosis disorder, and the rest, so the remaining 12%, were legal representatives. In terms of language, so we see that there is a majority of Dutch speaking compared to French. Age, so most of them were between 25 and 65 years old. Education, so also here, which was, I think, also mentioned by Charlene, so most of those who participated had some secondary or higher education. We had a very good distribution among genders. For the living situation, so in line with the language, the majority lives in Flanders, followed by Wallonia and then Brussels. Times to diagnosis. So as you can see, there were some people who participated who were just diagnosed less than 2 years, but also there was quite a significant number who were already diagnosed for more than 20 years. And then lastly, housing situation. So most of them, almost 50%, lived home alone with or without children. 27% lived home, but with other people, with parents or with a partner. And then the remaining 23 lived in a supervised institution. Okay, but now the actual results. So this is a visualization of the conceptual need framework, which was explained previously. So for the first part of the results, I will focus on the patient level. What are the actual needs of those patients? To start with their health needs. So which health issues do they experience? First, what we see in the results is that the quality of life drops after symptom onset. So as you can see on this graph, we asked patients to rate their general health state before they experienced any symptoms. Here the median was 80, but then after, so at the time of completing the survey, what was their general health state then? And here we see a median of 60, which means a reduction of 20 points, which is a significant outcome. Also, we saw that, for example, for age, younger adults, so people between 18 and 25 years old, show a deeper decline compared to the other groups. Psychological symptoms, of course, very important. And also here from the results, we see the psychological symptoms are highly burdensome, experienced by the respondents. The list actually was longer, so there were many psychological symptoms reported, but these were the most occurring, of which the top 3 is fatigue or exhaustion, feeling down or sad, and loss of self-confidence. But all of these psychological symptoms were actually rated as very burdensome or quite burdensome by most of the respondents. Second, decline in daily activities and independence. So it doesn't stay with these symptoms. The symptoms and the condition really has a big impact on the patient's life. It disrupts their daily activities and their independence. For example, on the left, you can see the problems that patients experience with self-care. Self-care before the onset of the symptoms, there was 85% that didn't experience any problems, while after, it was only 56, so it's a reduction of 20%. Second, problems with usual activities, doing dishes, cooking, reading a book. Before, 55% didn't experience any problems, while after it was only 22, which is more than a 30% reduction. Also important to say here is that people in financially difficult situations, they even have a greater decline in performing these usable activities, and this was statistically significant. To give a little bit more context based on the interviews, some participants explained that, for example, watching a movie and just following a storyline becomes way too difficult. But also, once people experience a lot of psychotic episodes, it becomes way more difficult to take care of themselves, even when working wasn't an option anyway. Then, impact on sexual and reproductive health. So in terms of reproductive health, we see that over 1/4 experience problems. In terms of sexual health, more than half experience an impact on their sexual life. And also here, a greater impact was identified for those in a harder financial situation. So to wrap up, for this first domain, the health domain, psychosis is not only a medical condition, it is a life-defining event. It goes beyond just the symptoms, just the health impact. It really has an impact on their daily functioning. And second, financial vulnerability needs to be recognized as a health factor. Those in precarious situations experience greater burden. Okay, going over to healthcare needs. Care gaps and delays. So on the left graph, you see the time between the first psychotic symptoms and first contact with the psychiatrist. 23% indicated that they had to wait they waited more than 2 years before to seek help. And here also we see a difference in between regions. So Flanders, there is earlier health seeking compared to Brussels and Wallonia, which is also something that can be taken into consideration when defining policy, to give an example of how to apply these need results. Then on the right-hand side, yes, time between first medical appointment and the diagnosis. So here we see that 1 in 4 waits or has to wait 1 year to get a diagnosis. Barriers to accessing care. So we asked patients or participants, in the past 12 years, did you ever need care which you didn't receive? 35% or 50 individuals answered, yes, I did. And these were some of the reasons: very long waiting times, lack of qualified staff, fear of medical tests, and difficulties paying for care. Side effects are also very common and often very burdensome. So in terms of treatment, the treatment of psychotic disorders is a combination of prescription drugs and non-prescription therapies, such as, for example, psychotherapy. So when looking at the side effects of these prescription drugs, we see that in 85% weight gain was reported and also experienced as quite burdensome, followed by fatigue and affective blunting or a lack of motivation or interest. Again here, financial situation has an impact. People with a harder financial situation reported a higher burden of weight gain, memory problems, and fatigue. Many respondents feel insufficiently informed and not included in treatment decisions. It's not only getting the care, it's also the experience of care and having the feeling of being involved, which matters to patients. So here, for example, we see that the satisfaction with the quantity and the quality of information received about psychotic disorders was perceived by 40% as only sometimes, rarely, or never satisfied. Also in the interviews, it was a recurring theme. So people, for example, explained that when they got the diagnosis, so they said, you have a psychosis, they didn't know what it was, they didn't know the implications, and they really felt that they didn't get sufficient information at that time. Level of involvement in treatment choice and satisfaction with the involvement of the treatment level. Here, almost 90% reported that they didn't feel included in their treatment decisions, which is a very important aspect to their care experience. So to conclude, psychological well-being, autonomy, and access to care matter just as much as symptom control. So it's not only symptoms, it goes broader than this, feeling heard, supported, and involved in their treatment decisions. Many barriers to care are structural and not individual. As we have seen, there are long waiting times as experienced by respondents, staff shortages, and financial strains which need to be considered in our policy making. Then we come to the last domain at the patient level, social needs. So psychosis impacts relations and education in a very significant way. More than 70% feel an impact on their personal relations, and more than half experience an impact on their education. Impacts on work. So long-term work participation and financial situation, which are related, we could say. So at the left, more than 30% was not working for more than 6 years already at the time of the diagnosis of the survey. Financial situation, more than half experience an impact on their financial situation. So in terms of social needs, we see that because psychosis often starts early in life, the disruptions accumulate. It starts with education, an impact on their education and trajectory, followed by an impact on their work, and then ending with a financial impact. Social isolation and financial instability amplify illness and slow recovery. So it's important to take into consideration these financial impacts, but also the social impacts to really help and reintegrate these people into society. Then, as also discussed earlier, this is a new criterion or a new question in the survey where we ask individuals to rate their needs. The 3 top ranked needs are treatment effectiveness, impact on your psychological health, and access to healthcare. Although overall we see across domains, across needs, that people rate nearly every need as a high priority. Unmet needs are broad and interconnected, and there is still a lot of substantial work to do to support individuals with psychotic disorders. We can conclude from these results. That was it for the patient level. Very briefly, still the societal level. So within the societal level, as previously explained, there are various criteria and indicators linking back to financial aspects, but also societal aspects. But here for this presentation, we limit ourselves to the survey, results of the survey, which cover the impact of psychotic disorders on informal caregivers. Even though only 14 actually participated in this survey, we see that the impact on the caregiver's health and social life was substantial. So also here, key takeaways, impact on the caregiver's health, but also social life is very important to consider. To conclude, psychosis is more than just a medical condition. It affects social, educational, and economic dimensions of a person's life. And the NEET evidence hereby, or we hope that the NEET evidence highlights an opportunity to create a more inclusive society. So this was my presentation, but before I start, some acknowledgements to, of course, the NEET team to make this work possible, but also to my dear colleagues at KU Leuven. So the research was supervised by Professor Isabel Huis and Professor Ruud van Winkel, and my dear colleagues here present, Io and Vicky, for also making this presentation. Then we have Cesano, of course, also for supporting the NEET project, Pierre Oswald and Geert van Isterdaal from the Uilenspiegel, a patient organization who supported the design and the validation of all methods and results. Thank you very much.
Thank you very much, Zilke. I think it was a very nice example of how the NEET framework comes to life, how it can actually play out. We're running slightly behind schedule, so we're going to shorten the Q&A session slightly, but we still have room for a few questions. So is there a question from somebody here in the room or from somebody online? I'm sure you're all aware that, yes, the questions are standing between you and lunch, so this may be a bit of a barrier, but
Thank you. My name is Arno de Potter. I work in the International Relations Department of our Federal Public Health Ministry. My question specifically for both of these types of research, they are very much prone, well, prone is maybe a negative connotation, but they very much include values from patients after reporting that are very subjective. So my question is, and I guess both of you might be able to give an answer, on how you are trying to weigh and objectify these subjective measures, these more emotional values that patients give to different of the categories that you are inquiring about, and how to give them a weight to finalize your results and measure the importance of them. Thank you.
Can I go?
Oh, yeah.
Yeah.
Go. No, go first.
Of course, the method is a very methodological question, and the method design was done by KCE, but I can give my own interpretation. So what is important here, I think, is the fact that the NEET framework combines various methods. It does allow triangulation of methods, so it does include literature reviews, but also expert opinions. So I think hereby we kind of can cope with or mitigate this challenge, but even though I do believe that patients' experiences, patients' values, and patient-expressed needs are still important to be considered in policymaking.
Yes, and I agree with that, and I will say that some of the indicators and some of things in life are subjective, and it doesn't mean that we don't have to assess them, and I think it's a very good question. And I agree that one of the ways is to triangulate with other data, and I think we have a lot of different ways to make it a relevant interpretation, and I think all is in that, in fact.
thank you. Is there another question from the audience? There's a question online? No. Okay, I guess you're hungry. Yes, there's one in the back.
Thank you for the very interesting presentation. I was wondering, when you adapted the survey specifically for people with psychotic disorders, did you then also include the qualitative aspects of people really experiencing these disorders to add to the generic survey, or was this not in place to do?
Yes. Okay, it's still on. Yes, thank you very much for this question. I think it's a very important part also of applying these need tools to a specific condition, because every condition is different and every condition has their own particularities. So this was a very special one, I would say, because it was also the first time KCE applied it in a psychological setting. So yes, methodologically, yes, we included patients or people with experience of psychotic disorders. One via Geert, who was involved in design, so he really designed it with us, but also by testing it with people who have the experience. And then in terms of what the impact was on the actual survey, we do have a paper submitted on this specific aspect. So what was adjusted, what were the tweaks that were done. It's not that we were able, or we didn't include new indicators or new criteria to the list, but we did make sure that the questions we were asking were relevant for the people who would respond to it. We would also adjust how it was phrased for them to understand what we were meaning, and also to not make it too stigmatized or to offend them in any way. So that's the main considerations we took into account when adjusting the materials.
Yes, one question here in the middle.
Thank you. I have one question for the research on psychosis. You showed some results about the impact after onset, negative impact on way of life and so on, but you also showed negative impact after, or some of the negative effects of medication. Do you have any way of knowing whether the negative experiences after onset are related more to the unintentional effects of the medication or more to the onset of the illness? Thank you.
That is a really good question. I would say, first, we do also have these interviews. So, of course, via the qualitative insights that we gain from the interviews, we do already get a sense of what is inherent to the disease and what is can be attributed to the medication. But besides that, we do, of course, also ask the treatment they receive, the particular individuals. So we could test it. We could statistically assess whether we see any correlations. So this is something that we could do. Of course, it depends on power and the sample size. So statistically, we could have some indication, but of course, it's never really possible to say it with 100% certainty.
One final question, I think then we need to wrap up. Yes, here in the middle of the room.
Thank you. I have a question about the NEET study is very pathology specific, but aren't there a lot of needs that are very typical for all patients with chronic diseases or rare diseases? And well, that's something very fundamental. That's a question. How are you going to take in account that? Thank you.
You mean taking into account the difference in the across diseases?
Yes, because it's so pathology specific, and they say that there are, I mean, more than 2,000 or 8,000 rare diseases alone. So, well, it's a bit, because often in patients' organizations, usually they try to emphasize what patients have in common, and this is very pathology specific. So.
Yeah, I think this may be a question for some of the other researchers in the NEET project.
Thank you for the question. Yeah, it's definitely a hugely relevant question, and we thought about it too, and clearly there are differences by pathology and there are commonalities between pathologies. We kind of had to choose an approach. So the approach had to be, we thought about this, would there be any way of kind of measuring transverse needs across the whole population? Because you also have comorbidities. right? That's another huge difficulty methodologically. We know that, of course, the burden is also increased if you have more than one disease. And yeah, they can interact between them, these burdens from different diseases. But we just had to choose one approach. And the easiest approach also, which could be maybe more relevant in order to develop innovations, to improve healthcare services, was to name the disease, at least to have that information. I think in the future, if we saw that, we find that with a certain type of diseases, the needs are always the same, then we could move even more quickly and kind of gather data more quickly, thinking that it applies to many other diseases too. So, yeah, unless you have any other bright ideas, you're welcome to submit them. Thank you.
Can I maybe add to this? It's an academic involvement, I would say. It's not part of the KCE NEET study per se, but specifically for rare diseases in Leuven, we recently have the Leuven Institute of Rare Diseases developed specifically for the UZ Leuven, the hospital. And there, within the project, a big research endeavor would be to assess these needs across rare diseases, but at a local level, and also via a simplified needs survey, because it's indeed, some questions are very specific and it will be very difficult to get answers all over the various rare diseases. But I do think there is some value in having a general idea of the commonalities, as explained earlier, specifically for rare diseases. I think this is a case where it's particularly relevant. And my colleague here, Genji, he will be working on this. So if you're interested, he can always use some insights.
Great. I think that's an excellent time to stop this session. Thank you very much for your contribution to this morning's sessions.